they have like this tool that they put here in the. I saw it in the TV home, and they go ahead and like drill you to your bone and do like it because you don't have time to find an IV. So that's horrible. Yeah, it is horrible. But cool at the same time.
I don't want to be hospitalized. That's what I'm.
Yeah, critical care seems cool until you're there.
That's the rotation you're trying to do with SPH.
Critical care? Critical care, really? And then I just had a meeting with Dr. Because I have to operate my knee, right? So I don't know. Next, after next year in summer, when classes finish, my break is gonna be in an operating room.
And they're right into Abby's.
Yeah. With a destroyed knee. You guys competing in the clinical whatever skills?
Yeah.
Please go. There's a workshop tomorrow.
Okay, guys. Oh wow, this is like too loud for me. I think my voice is good. Okay. All right. Long time. It's been a week, but I feel like it's been like longer. But I hope that you guys have been just enjoying this last set of things leading up to the last exam with Dr. Hall and Dr. Joshi. Right off the bat, I'll say arrhythmias is my least favorite cardio topic. I'll teach it and I'll try to make it as simple as possible, but it's not my favorite because there's just so many drugs. There's like way too many drugs, but we only use a few. So my goal will be to highlight the ones that we go to, the ones that you should be aware of, but there's going to be a lot. So just try to like tune the noise out. There's a study guide that's posted for you. It's called Arrhythmias Clinical Info Must Know, something like that. And so I would recommend you just go through those bullet points, make sure you're comfortable in answering them after the lecture, and let me know if you have any questions. And then also just as far as the module goes, so just so everyone's aware, exam for this content it'll be next Monday. Again, be sure to attend class on Friday in order to get your full score on Monday. So in case you don't show up on Friday, there will be a potential percentage deduction. I should say definite. Yeah, there's going to be deduction if you don't come on Friday. So please, we are ensuring that, trying to honor what you all unanimously decided in return for something that we would like for you to attend and be participating in. So that is that. I have 12 questions tied to this lecture right off the bat. 12 questions from me, 23 questions from Dr. Joshi, and then I think it's 15, whatever the rest is. Yeah, 15 from Dr. Hall. So that is just to give you a breakdown. I don't have that many questions because I only had like one lecture, this one. So we'll get right into it. But before that, any questions about anything so far with the module, with anything else? This is unrelated. Sorry, I just have to mention top 200. That's coming up next week. So there's a little bit of time, but I did post the drug sheet, like drug review sheet for endocrine. It's going to be the endocrine quiz. So it is posted for your review. My apologies. I had it noted to post sooner, but I got around to it, I think yesterday, like late. So just so you're aware, it is now there for your review, and that is that. But yeah, any questions before we get started? Another thing, yes. So if we don't get through all the material today, I'm not worried about that. I do have a recording for this lecture that I did just in case. So I will post that for you, and it will cover everything in the slide deck. So just in case, I was like, I'm going to prepare for the worst, because we just have this one class period and it looks like a lot of slides, but again, I'll try to be as to the point. So, okay, without further ado, that took up more than I wanted, but okay, getting right into it. So just some learning objectives. We'll go through review of an EKG or ECG. Those terms are used interchangeably. We'll go through some common QT prolonging medications and then other risks for a condition called torsades. Torsades de Pointes, TDP. This is a life-threatening arrhythmia, so we'll talk more about that. Compare and contrast the efficacy, safety, and monitoring of antiarrhythmic medications. We'll go through the goals of therapy, classify goals of therapy for atrial fibrillation, which is the most common type of arrhythmia. We'll go through the different types of AFib, atrial fibrillation or AFib. We will go through the risk factors for the development of AFib. We'll go through the first-line agents for rate control and rhythm control in the management of AFib. We'll go through the stroke risk in a patient with AFib using the CHADS-VASc score, which is like a scoring criteria, and I'll explain the details when we get there. And then we will work through developing a treatment plan for a patient with AFib. Tomorrow, you will get more hands-on practice with an actual anticoagulation and an arrhythmia case. Hint, hint, it's going to be an AFib case. So just because that is clinically what is seen more than any other type of arrhythmia. So managing that would be my key focus. So we'll get into that. This is an FYI slide. Recommended read. Okay. Introduction and clinical presentation. So just as a background, arrhythmias, they are basically an abnormal heart rhythm. This can cause the heart to beat too slowly, too rapidly, or erratically. Slowly would be bradycardia, rapidly tachycardia, or erratically, which is just this abnormal state where it's not really in any sort of direct pattern. Any disruption in the normal sequence of impulse conduction could result in a cardiac arrhythmia, and that could lead to the following complications including altered automaticity, triggered activity, reentrant circuits, conduction blocks. So just some things to be watchful of. Okay, and then arrhythmias, they can be classified by the patient's heart rate. So as you're aware, a normal heart rate is between 60 to 100 beats per minute. So this should hopefully make sense. Tachyarrhythmia or tachycardia is classified as a heart rate of greater than 100, and then Brady would be less than 60. They can be classified by location of origin, so basically where they happen in the heart. Supraventricular arrhythmias, they happen above the ventricles. That's why there's the prefix supra. So that includes atrial fibrillation, which is, again, the one arrhythmia that we'll focus on quite a bit. And then there's others listed for your reference. Ventricular arrhythmias, those happen within the ventricles of the heart, and those are considered life-threatening. Those are major, and we want to avoid those from happening. And that includes torsades, which is one that we'll discuss further, just in terms of management and how it can be fatal. So we have to be trying to steer clear of that. So these patients, they may or may not have symptoms. In the situation that you do see symptoms, you'll see things like chest pain, palpitations, shortness of breath, feeling dizzy, fatigue, feeling lightheaded. Those are the more common types of things that are seen. And in some extreme cases, arrhythmias can be fatal. So just some things to look out for. Okay, and then this is just an overview of an ECG or EKG. Both are the same thing, just used interchangeably. I say either or depending on like whatever whatever flows off my tongue. And EKG, ECG, it provides a graphical picture of the electrical activity of the heart, typically over 10 seconds. And it's like electrodes that are placed on the limbs and the chest as shown. And the EKG is used to diagnose arrhythmias after assessment of the patient's clinical history and physical exam. So this is our confirmatory way of making sure if a patient actually has an arrhythmia or not, which makes sense, right? And then here's some monitoring devices of how we check for an EKG or ECG. The Apple Watch also has this feature, which is kind of cool. So like if someone has new onset or continued any sort of like arrhythmia, then there is that feature available on the Apple Watch. So you can see some of the other things that keep tabs or keep track of that, but that is that. Okay, as far as the EKG or ECG goes, just going to give you a super high level understanding of this. I'm not going to ask any questions pertaining to this. This is not like something that you need to know super in detail. But this essentially like where you can see the cardiac action potential, which I'm assuming Dr. Joshi covered with you all. Yeah. So like you probably have a good understanding mechanistically where all the antiarrhythmic drugs work. Just looking at the far right box. So you can see just like P wave, PR interval, QRS complex, ST segment, T wave. Rather, this isn't the action potential. I'm mixing that up. My bad. But like, as far as like the depolarization, AV node, SA node, depolarization, like all those things, you can kind of get a sense of where pharmacologically our agents would come into play. So this just kind of, lays out like what the strip would look like. And the key elements that you all ought to be aware of are on the next slide. So just, in general, we know that a normal heart rate or ventricular rate is anywhere between 60 to 100 beats per minute. The rhythm regularity, it's supposed to be regular, meaning there's equal distances between the RR interval. There is a P wave, QRS, T wave, all those things are present on the EKG strip. And they should look the same in each cardiac cycle. And you can see this, like such an example at the very bottom, that's considered normal. The P waves, they're present if the rhythm originates in the SA node, atrial node, and it should be upright, identical. There's one, like a mini, as you can see here, right before each QRS complex. And this interval is 0.12 to 0.2 seconds. QRS complexes, those are narrow, and those are 0.12 seconds or less. And then the QT interval, which that is supposed to be either 440 milliseconds or less. That's what's considered normal. A little bit later in the presentation, you'll see like there's cutoffs for men and for women. So it's a little bit different as far as men, like what's considered a long, prolonged QT for men. And then for women, it's a little bit higher. So we'll get there eventually. But on the study guide that I have, it's indicated on there just like what key information you should be aware of, just so that you know like what is key to take away from this. And then here are just some other EKG strips that you can compare to the normal sinus rhythm one. You can see just in general, like the arrhythmia one, all the complexes are normal, but the rhythm is irregular. The bradycardia one, everything is like pretty evenly spaced, but the rate is slowed down, and you can kind of see that like they're more spaced out. Tachycardia, it's happening more frequently, but the complexes look normal and they're evenly spaced. The AFib one, you can see that's considered irregular, which you have an irregular ventricular response and the baseline, like it's just kind of squiggly lines in between, which is not what it should look like. And then our life-threatening arrhythmia, which is ventricular fibrillation, that one you can see is just like, there's no order to that one. It just looks chaotic. Rapid, wide, irregular ventricular complexes. So yeah, that's not something that we want. This slide, I'm not going to really go into this because again, I don't think it's a good use of our time. Like it's just kind of review, and I'm not really going to ask questions tied to this on the exam. So just going to keep it moving. Now we'll shift gears, go into expanding on QT prolongation and torsades. Does anyone have any questions so far about anything that we covered? Okay, cool. Okay, so QT prolongation. So the QT interval that's measured from the beginning of the QRS complex to the end of the T wave on an EKG, and this reflects ventricular depolarization and repolarization. There's an equation, which again, you're not responsible for because the EKG report indicates like both values to you. So there's no point in manually learning how to like calculate it. It's just more so for your reference. There's something called the QTC, which is considered the corrected value. And that's what we go off of if we want to consider someone having a prolonged QTC. So prolonged for men, as you can see, it's greater than 440. And then for women, it's 460, like above 460. So that is something that is reported on the EKG report. We look for that value. And then if it is considered prolonged, then our concern is we are at risk for having our life-threatening arrhythmia, aka torsades. So we don't want that to happen. A QTC of greater than 500 is where we are really entering that zone of like being at risk for this arrhythmia. But yeah, we start to get concerned as soon as it's like starts to go or creep up above the normal cutoff. So that is actually very commonly done. I was at my site earlier today and like there was a medication that I caught that like was doing this for a patient, so had to hold off on continuing it. Because again, like it's going to lead to a life-threatening arrhythmia for the patient, and we don't want that. So that is that. Okay, prolongation of the QTC, it's considered a risk factor for torsades, as we have been discussing, and this is lethal. It's a ventricular tachyarrhythmia, which can cause sudden cardiac death. And then torsades des points, so French for twisting of the points. And the way that we manage it is we give magnesium. So we'll get to the risk factors for development of torsades, and it'll hopefully make sense why. Like we're just giving straight magnesium to manage this condition. It's given IV, 1 to 2 grams, given all at once. And that helps to resolve this condition. And you can see the EKG strip at the bottom. It looks very scary, just like all over the place, and there's no rhythm, order, nothing to it. So that's what it would look like. Okay, so some risk factors for this arrhythmia. There are some that are modifiable and then some that are not modifiable. And we've been practicing this throughout the module. So some patients, they just have a prolonged QT at baseline. That's just, what it is for them. It could be genetic. It could be just like they're predisposed to having a prolonged QT, and it's harder for us to regulate that. So that's like more non-modifiable. The female gender obviously can't do anything about that. Underlying cardiac disease, to some extent that's modifiable by making sure that the patient controls their cardiac conditions well enough. Other than that, underlying renal and hepatic impairment, hypokalemia and hypomagnesemia. So those are the two top modifiable electrolyte conditions that we want to rectify before anything. So in this situation that, a patient has low potassium, low magnesium, we replete them and try to get them to goal. And, by goal, I mean a potassium of at least 4 and a magnesium of at least 2. This is like a common goal that we try to aim for in clinical practice. So does anyone remember what like a normal potassium range is? I'm hearing, yeah, that's good. 3.5 to 5. Okay. So greater than 4, you don't want to like the upper end would be trying to keep it less than 5. So it's a little narrow, but like basically you wouldn't want it to exceed 5 when repleting. So so that's that. And then does anyone remember magnesium? That's a little bit harder. Like I have to refresh my memory of that too sometimes.
I think until 4, 3.
Kind of, yeah. So aim is to keep it above 2. I think it's like 1.8 to maybe 2.5, and I think it's a little different everywhere, but it's very, very narrow. We barely have like one whole range in between. So unfortunately, like just kind of have to keep an eye on that and then make sure that, try to keep it as best as above 2. So those are the two key things that we try to fix right off the bat for patients. Yes.
We fix first, like if the patient has both, we first fix the hypomagnesemia, right? Or
if the patient comes in with torsades, then magnesium is the first thing we would do. Yeah. And then if after that we know that they're hypokalemic as well, that would come after. Yeah. So management of repleting that. Mm-hmm. But yeah, magnesium is the key electrolyte that helps to reverse, is considered disease modifying basically.
Is it safe to assume therefore that if the patient has to start, the patient must have hypomagnesemia?
Not necessarily. Even if say like their magnesium is normal, and even if it's like maybe above the upper limit of normal, it's still considered clinically the most effective treatment option to go about magnesium treatment. Yeah. Yeah. And then magnesium is the type of electrolyte that excreted. So like it's not the type of thing where it'll necessarily circulate and cause other issues. Plus we're using like a lower, magnesium dosing can be pretty aggressive. It can go all the way up to like 4 to 6 grams. So we're aiming at first like 1 to 2 grams, which hopefully, is going to do the job. So yeah, so that's what we would do regardless. But at the same time, we'll keep an eye on the electrolytes, make sure that they are within normal range. So yeah, good points. And then medication-related factors. So these hopefully are straightforward. Higher doses of QT prolonging medications, they're going to predispose the patient to developing torsades. Multiple QT prolonging drugs, or drug interactions that could decrease the clearance of QT prolonging drugs. Okay, and then you can see here, there's a lot of medications that can prolong QT. And when studying for boards, which I know is not happening yet, but it's coming up, you will see the resource for studying for the NAPLEX. It's going to lay out all the therapeutic classes very nicely for you. So you'll see just kind of the different therapeutic classes and agents that could potentially do this. For the purposes of the exam, I would say the ones that are in red, being familiar with those is probably ideal. And just to give you a heads up, tomorrow, this will come up again, just so you get more practice with being familiar with the QT prolonging medications and therapeutic classes. The one thing I want to point out is cardiac medications. So we're going to go through the antiarrhythmic medications. The irony is that they are antiarrhythmic, but then they cause proarrhythmia. So it can be a little bit tricky in terms of using them. And that's why a lot of them, they've actually fallen out of favor, which is they're on the market, but they, we don't really go to them or resort to them as frequently as you'd think. So yeah, it's just an interesting effect, but The other therapeutic classes, like we have antidepressants, antipsychotics, antibiotics, antifungals, methadone, donepezil, like these are common medications that could lead to QT prolongation. Okay, so going into antiarrhythmic medications, any questions about that? Again, QT prolongation or Torsades management is with magnesium IV, 1 to 2 grams, and you push the drug. So that is that. Okay, so this is basically in a nutshell all the medications, the antiarrhythmic medications, and they're broken down by class. You can see there's classes 1 through 4, and there's a nice little mnemonic that's on the far right. Double quarter pounder, lettuce mayo, fries please, because dieting during stress is always very difficult. Yeah, I didn't come up with that. That's actually I think by one of the board resources. Like it's in the NAPLEX book, or it's in one of those books. So the test makers, I think they did this, which it's very creative. I give them that. But as far as usage goes of all of these, as I mentioned, we don't see all of them being used frequently. They are available on the market, but the way that you will see them, you're only going to see a select few. So I'll say right off the bat, please don't be overwhelmed. It's a lot of agents, a lot of names, and there's nuances with each one. But anyway, I'll highlight the ones that you really ought to be familiar with. Class 1, you can see it's broken down by duration of action. So there's 1A, 1B, 1C, intermediate fast, long acting. And we'll get into which ones you need to be familiar with. Class 2 are beta blockers, good old beta blockers, which we've been seeing literally all throughout the module. So the same ones that you see, the ones that end in OLOL, those are class 2. Class 3 are potassium channel blockers, and we'll go through the more commonly used ones. And then class 4 are our calcium channel blockers, specifically non-dihydropyridine calcium channel blockers, verapamil and diltiazem. So these are reserved pretty much for arrhythmias. We've introduced them before and introduced them in the context of heart failure. So if a patient has underlying heart failure, you do not want to use these. But if a patient, say, has hypertension and they have an arrhythmia, then these work really well for such patients. So that is that. Okay, I've kind of already mentioned this. So class 1 and 3 antiarrhythmics, they have declined, usage of them has declined because of clinical trials showing increased mortality with their use in several situations. And then they have pro-arrhythmic potential, meaning causing additional arrhythmias and complications. And the advancing technology of non-drug therapy, such as ablation and ICD or pacemaker placement. And we'll talk more about those eventually. But again, we'll point out the ones that we do use. This table, so I will just go through this. I won't read every single thing here because I'm not going to test on any of the class 1 agents. They're here, they're for your reference. You can see there's just as a heads up, the one that we might see in the acute care setting is lidocaine out of everything else that's listed here. Some institutions have more or less of these agents, like flecainide I've seen at a previous institution where I was working. But I would say lidocaine is probably the one that is pretty standard. It has a more of a fast onset of action. So it works really well, again, in the more of the acute state of a patient, used for ventricular arrhythmias only. So in this situation, again, where we have an emergency going on, lidocaine IV is our go-to in that situation. Everything else, I'd say kind of not really seen besides, the lidocaine is probably the only one that I would point out. And then class 3, so from here, I will point out dofetilide and amiodarone. Those are commonly used. The reason is because they can be safely used in structural heart disease. So in patients who have underlying heart failure, these are considered the drug of choice. And a lot of times these patients have some sort of underlying structural condition that's happening. So for that reason, these are our go-tos. The other ones are there as well, like dronedarone, sotalol, ibutylide, like they're available on the market commercially, but as far as usage goes, they're a little bit more specific and like conditional with when we would use them or resort to them. So I'll just point out dofetilide and amiodarone as the ones that you should know. Amiodarone is the most common antiarrhythmic that we use. That one you should definitely be familiar with. That is on top 200. So you, to some extent, already have an idea of what it entails. So we'll talk a lot about amiodarone later in the lecture. But yeah, that's pretty much it for the class 3. And then the other two classes, class 2 and 4, 2 is beta blockers, which you already, again, have seen before. And then class 4, calcium channel blockers, diltiazem and verapamil. Those aren't new. So those are we're just going to review them a little bit later. But that's pretty much an overview of the antiarrhythmics and what you ought to keep in mind. So we'll go through the details of everything. Okay, so this quick question, which of the following regarding torsades is false? Take a second to read through and then let me know what you all think. I heard B. Is that right?
Yes.
Thank you. Yes. So potassium, although hypokalemia may be a risk factor for developing torsades, we don't use it to treat that type of arrhythmia. Magnesium is the only treatment of choice. So that's what you should keep in mind. And then everything else, all the other statements are correct. So therefore, that's not the right answer. Okay. And then here's just a matching activity. Again, I had this from years prior. I'll just quickly go through these. So you don't need to worry about mexiletine, flecainide. Verapamil is class 4, right? Because that's calcium channel blockers. Sotalol is class 3. Metoprolol is a beta blocker, so that goes in class 2. And then procainamide, also don't worry about that. So class 1, you basically don't need to worry about any except lidocaine and knowing that IV lidocaine is used in ventricular arrhythmias. Okay, and again, ventricular arrhythmias are the ones that are emergency cardiac arrest, the life-threatening arrhythmias. Okay, here's another. This one actually goes into, the answer to this is quinidine. So there's a patient that has ringing in his ears, blurred vision, and confusion. There won't be a question tied to any of the class 1 antiarrhythmics on the exam. And again, I don't really want to go into that. So don't worry about this question, but just if you're wondering what the answer is A, quinidine, which causes something called synchonism, which is this tinnitus, ringing in the ears sort of sensation. So that's what that's asking for. Okay, any questions? That was a little chaotic, but I think things will become a little bit more clear as we move forward now. So we're getting into AFib, which is our most common type of arrhythmia, the one that's seen most often in clinical practice, and knowing this is really key. Okay. AFib, it's as mentioned, most common sustained cardiac arrhythmia. Some background. So the atria fibrillate, which cause disorganized electrical activity, ventricular contraction. The atria don't fully empty, which cause blood pooling. The blood pooling can lead to the formation of a clot. and that clot could potentially travel to the brain and cause a stroke. We will talk about management of that later, but essentially because there's a clot, you all had anticoagulation with Dr. Hall. You know how to like manage that, right? Like with our different anticoagulants. So we'll talk more about that eventually. But just so you know, pathophysiologically, there is this concern for stroke for certain patients. Fibrillation of the atrium may cause the ventricles to beat very fast. And then that could lead to ineffective pump function of the heart. So this could either cause the development of heart failure or worsen underlying heart failure. So a lot going on with this and things that are wrong with this, but we have measures in place to manage AFib. So this is what an EKG looks like for a patient with AFib. You can see an irregular rhythm, and there are no P waves. They're not discrete. So it's just kind of like all over the place, considered irregularly irregular. And then in terms of classification, so there's like 5 different subsets, as you can see, and they're all defined a little bit differently. There's paroxysmal, which happens sometimes and then stops on its own without intervention. And the heart returns to normal sinus rhythm within 7 days of onset. The episodes can happen with variable frequency. With persistent AFib, this is the kind that does not stop on its own and it's sustained beyond 7 days, but it can be cardioverted. And then long-standing persistent AFib, that's where we have AFib for greater than 12 months. There's permanent AFib. This is where both the clinician and the patient decide, okay, well, we're not going to be able to restore and maintain sinus rhythm anymore. Like this is, considered refractory or, not really much can be done at this point. And then there's also valvular AFib. This is where the patient has moderate to severe mitral stenosis or with a mechanical heart valve. And for that, we have to do anticoagulation with warfarin. So lots of different types. In terms of the most common types that are seen, I would probably say paroxysmal. So the kind that like happen and then they stop on their own. So the episodes they happen and with variable frequency. But then you may see a fair share of like persistent and long-standing persistent as well. So that's that. Risk factors for developing AFib are age, male gender, cardiac diseases, obesity, hyperthyroidism, certain stressors and drugs as indicated. And then again, I would recommend just kind of working through the list and identifying what is modifiable, what is not modifiable, because that's always, a key thing to keep in mind for like trying to help these patients out. Like what are some things that we can fix and what are some things that we can't do anything about? And then symptoms wise, similar to just kind of the overview that I gave with arrhythmias in general, some may not have symptoms, but if they do, typically they present with like things like palpitations, shortness of breath, fatigue. And then some severe things could be like heart failure related. So having an exacerbation, buildup of fluid in the lungs, severe hypotension. So like more in that shock sort of state. It could also cause angina, so like something ischemia related. So those are some possibilities. Okay. And then these are just like an overview of the guidelines that exist for AFib management. ACC-AHA, as you've seen for other disease states that we've covered in the module, like they are the body that puts together the evidence-based recommendations. So that is that. So let's work through this, this practice case. There's a patient that was diagnosed with AFib 5 years ago and has had multiple failed attempts at cardioversion. This patient and his physician, they decided to no longer attempt to achieve normal sinus rhythm and will leave the patient in AFib. So based on the classifications we just went through, how would you categorize, how would you classify this patient? I'll go back to the slide. permanent. Yeah, permanent. So in this case, the patient and clinician both decided to stop further attempts to restore sinus rhythm. So it's kind of at that point like last stage, or we can't really do anything about it at that point. So you can see that is indicated on here. Okay. And I will say, like, there will be similar things to look out for on the exam. So meaning I'll give you like a scenario, and then you'll basically need to know, like, based on the classifications, which type of AFib it is. Okay. So with AFib, we have these two approaches. We have rate control and rhythm control. And we'll go through the details of that. So our rate control strategy, this focuses on controlling the ventricular rate. Now, what this means is the patient has underlying tachyarrhythmia. So like they have tachycardia or an elevated heart rate. Our goal is to bring it to goal, and I'll specify what exact goal we have for these particular patients. So our rate control, that's like our number one approach. That's for all patients with AFib. Some patients are candidates for rhythm control, but not all. So this is where we try to restore and maintain normal sinus rhythm, but not everyone is a candidate because at the bottom you can see that like there were some pivotal trials that indicated to us that there was no mortality benefit with rhythm control, and the rates of hospitalization were actually higher in the rhythm control group. So that just goes to show that like not everyone needs to get both. Rate control is kind of our first step, and then that usually does the job. So once we get that, achieved, then that's really the key thing that we need to aim for to be able to do. Okay, and then you can see here the first line treatment options. Beta blockers are go-to. They are preferred. You've seen beta blockers used across other disease states. They are like the OG. You definitely need them in a lot of things. And yeah, for rate control, beta blockers are the class. If for whatever reason we can't give a beta blocker, then we have our non-dihydropyridine calcium channel blockers. They can also be given in conjunction with the beta blocker if our beta blocker isn't like enough. So you can add on diltiazem or verapamil. They are still to be avoided, though, in patients with reduced ejection fraction. So what we covered with heart failure, that still would apply. We would not want to put the patient at risk. So in that situation, we could add maybe digoxin on top of the beta blocker therapy in patients with reduced ejection fraction. So digoxin is a very difficult drug to deal with. We briefly we didn't really go into detail with it in heart failure, but it's kind of like that add-on treatment option. So it's approached kind of in the same way for AFib. Like it's there, but it's not our first line by any means. Okay, so these are the goals that I was alluding to earlier. A goal resting heart rate of less than 80 beats per minute is recommended for patients who have symptomatic AFib, or if they have left ventricular dysfunction, aka an EF ejection fraction of 40% or less. So basically have FREF. And again, this says and or, but you could look at it as like either or. Okay, either symptoms or they have EF of less than 40. Okay. For them, we are stringent with our heart rate goal because outcomes for them are a little bit worse because of their symptoms, because of their overall structural heart disease extent. So that's why we have to be a little bit more tight control. For patients who are asymptomatic, and this is not an or thing, this is an and thing, and they have a preserved left ventricular function, so an EF of greater than 40%, we have a goal heart rate of less than 110 beats per minute. So for them, it's a little bit more relaxed because outcomes for them aren't as extreme. We're not as worried about being as strict with our heart rate goal for such patients. These numbers, again, they're like evidence driven. So essentially better outcomes are noted with these particular cutoffs. So that's the thought behind that. Any questions? Do we want to take a break? Okay, let's take a break. Let's take like 5 minutes. But we're actually doing good on time. Hello.
Question regarding, because I want to share regarding the patient that not passed. Here, have a remediation
There will just be something
because it is saying the tomorrow, yes,
Yes.
but I am sure, I don't know, I prepare myself because I 68, but I know that I'm not going to pass because I know. But if it's near to 70, do I need to take it or?
Yes. Yes. So it will just be like good to review your the missed questions, and then you can ask any questions. Dr. Colleen and I think Dr. Gonzalez too will be around, and then retake those questions.
Okay, so
That's how
the
it
question that I failed. Okay, I know what.
Okay.
In what then I failed.
Okay.
So it's going to be tomorrow or it's going to
Yeah,
be
I'm
for
gonna
the-
see because tomorrow I'd rather have full time for the piece. So I think Friday at some point, Friday before class,
Okay.
I'll probably set up a time.
Okay,
Yep,
thank
yep.
you. Thank you.
Yo me voy a quedar porque en verdad me necesito concentrar y me voy para el piso. Porque me quedan 3 lecciones. Pero como ya te dije, ya yo descansé. So,
Yo no puedo dormir bien.
es que yo pienso que no estamos bien. Como que yo por lo menos la mente se me queda despierta a todo lo que tengo que hacer al día siguiente. Y como que no, tampoco se me hace
A mí se me olvida comer, entonces tampoco me recuerdo que estoy ya durmiendo.
A mí me pasa lo mismo.
Yo ya ayer comí,
Yo
se me olvida eso.
yo sabía lo que
Y después llego el examen, estaba y él está como, mamá, ay,
Me pasa como
eso no se olvida.
a veces se calma.
She's beautiful. Yeah, she's having these days. She's like us right now. She's seeing patients and
Es que yo lo confundo con dolor de cabeza.
yeah, she's assigned to a
yo como bastante.
psychology center. So she's already seen patients, working on outfits. Yeah, it is cool. But she's learning, how to deal with pain. And psychology is thing. So you have to
Either think like a patient or don't.
yeah, I don't know. I couldn't do psych or psychology.
I salute her. I teach psychology. I don't.
Yeah, but she's doing well, but she's stressed. We can't. We barely. Well, not barely. We talk to each other every day, but not as. She's okay. She's basic, but I'm gonna see her.
I know someone paragraph you know it.
Okay. Alrighty, we will resume. So for the sake of time, we'll just get back into it. Okay, so getting right back into what we were discussing. This slide just gives you an overview of beta blocker dosing as well as non-dihydropyridine calcium channel blocker dosing. No exam questions will go into this. This is just for your reference to give you a sense of there's IV dosing available, then there's also oral dosing available. And IV is of course more instantly bioavailable, handled or dealt, it's administered in more acute situations. Whereas oral is it works well for more maintenance situations. So, that is that. Okay, so this is just an overview of digoxin. Digoxin is an interesting drug. Again, not our first line by any means. It's a nice add-on. And it works well in conjunction with one of our first lines. It's safe for use in patients with heart failure. And again, you probably remember in heart failure, it's an add-on option. It helps to reduce the risk or rate of hospitalizations in heart failure patients. In AFib, it's kind of the same in terms of place in therapy. And as far as onset of action goes, takes a little bit of time to kick in, has a semi-long half-life of 36 hours. It's not really recommended for acute immediate rate control. So more as maintenance therapy, just to get patients rate under to goal essentially. And then you can see the typical dosing, also just FYI. When the creatinine clearance is less than 50, then you would reduce the dose or frequency of it. And then when you convert from PO to IV, the dose should be reduced by 20 to 25%. So that is just a clinical pearl, if you will. The IV is more bioavailable, right? Which makes sense. So you need less of the IV dose to achieve the same clinical effect as that of PO. So that's the idea. And then more details. So you can see we do therapeutically monitor digoxin. Our goal level is between 0.8 to 1.2. And we typically draw it about 12 to 24 hours after the dose is given. There is a different window for heart failure, just as an FYI. Heart failure is a little bit lower. It's 0.5 to 0.9. For AFib, it's a little bit higher. So there's a little bit of a difference with that. It's important to correct any electrolyte abnormalities, aka hypokalemia, hypomagnesemia, because digoxin can lower them. So that's why we want to make sure that those are taken care of. And then there's a lot of drug-drug interactions with digoxin. So in that way, not really the most favorable thing. It interacts with other antiarrhythmics. The signs of digoxin toxicity include GI disturbances, certain visual changes, neurologic manifestations. It's a lot of things, and it actually does happen. Like the blurred vision and yellow-green halos, those are totally a thing. And then if we ever need to reverse digoxin, there is an antidote for that available, which is kind of nice. It's called digoxin immune fab, digifab. Not all hospitals have it though. It is expensive. So that is one barrier, but in the situation that you need to reverse it, you can. This is nice practice. So like identifying what a patient's heart rate goal is. So say there's a 60-year-old male with a past medical history of heart failure with reduced ejection fraction and an EF of less than 35%, who has recently been initiated on carvedilol for rate control for his AFib. His heart rate today is 115 beats per minute, and he's not currently experiencing any symptoms of AFib. So what is our heart rate goal? Less than 80. Because remember, either symptoms or an EF of less than 40%. And then our second statement was less than 110, it has to be and. So an EF of above 40% and no symptoms. This patient doesn't have any symptoms, but they do have the condition of having an EF of less than 40%. So therefore, our heart rate goal needs to be more stringent. We have to aim for less than 80 for this guy. Does that make sense? So again, remember the or, that applies for our more stringent heart rate goal. And then for and, so that's the asymptomatic, and the EF has to be greater than 40%. For them, we aim for a heart rate of less than 110. So keep that difference in mind. Okay, here's a practice case with digoxin dosing. So IV to PO. So I guess, yeah, we can take a stab at this. There's a patient who takes digoxin 0.125 milligrams PO daily at home for rate control of his AFib. And he comes in with a therapeutic digoxin level. He will be NPO, so he won't be able to take anything by mouth for numerous surgeries over the next several days. What equivalent dose of IV digoxin should we recommend for this patient? So you basically remember, keep this bottom red statement in mind when converting from PO to IV. The dose should be reduced by 20 to 25%. So what do we end up with?
0.025.
I'm hearing 0.025. Do we agree? So the way that we would arrive to that is how? Like walk me through the calculation.
Multiply by 0.2.
Okay. So you would multiply by 0.2, but that gives you 20% of the overall dose. We need a reduction by that, right? Okay, I heard the answer, but let's hear some more answers. Any? So we have 0.125 milligrams daily. We're trying to reduce that by 20 to 25%. So you would take 0.125, multiply that by 0.2 or 0.25, Okay, you could do them stepwise, but after multiplying it by 0.2, let's take that one first. You should get 0.025, is that right? 0.025, okay? And then you take the 0.025 and you subtract it from 0.125 because you're trying to get basically 80% of the 0.125 dose, like meaning you're not, because the 0.025, it's giving you 20% of the overall dose. And that's like not what we want because we're trying to reduce it by 20%. Does that make sense to everyone, what I'm trying to say? Okay. So again, don't forget the final step because yeah, like with calculations and all that stuff that we've done before, remember to subtract your 20% reduction from the initial oral dose. So your answer should ultimately come to D, which is digoxin 0.1 milligrams IV daily. Do we all agree? Any points of confusion, or does anyone want to clarify that? D. D is the correct answer. Did anyone have any trouble arriving to that answer? So again, to walk you through this, you have 0.125 milligrams PO daily, okay? Multiply that by 0.2, which is indicative of our 20 to 25% reduction. I'm going to start with 20%, okay? Let's just start with that percentage, okay? I would recommend you do the same. Multiply that by 0.2, then you get 0.025 milligrams. This number is your 20% of the overall oral dose. It's not your answer. It's just 20% of the overall dose. What you need to get to is what a 20% reduction would be from the oral dose. So that's why you have to subtract the 0.025 from 0.125. When you subtract, that's when you arrive to 0.1. And then if you do the same thing with 25%, so like if you multiply 0.125 times 0.25, you get this like extended decimal, but when you subtract that decimal from 0.125, you still arrive at around like, I think 0.09 something. So it's close to 0.1. So that's the answer. Make sense? And if it doesn't, please come forward, let me know. Please talk to me about it. Okay, rhythm control. So this is our other treatment approach. Again, not everyone is a candidate for this. The patients who do benefit from rhythm control would likely be those who've had, like if they have an initial episode of AFib, if they are persistently symptomatic despite rate control, those who are younger, they tolerate rhythm control better. Patients with structural heart disease or heart failure, they also may be better candidates for rhythm control. But it's not necessarily for everyone, like rate control sometimes is enough. As for conversion to normal sinus rhythm, this can be done with antiarrhythmic drugs, some of which we covered already. And the other option is for us to do direct current cardioversion. We'll go through the details of that in the next slide. And then maintenance of normal sinus rhythm, that could be with drugs. It could be with catheter ablation. We'll go through the details of that as well. If the patient has permanent AFib, then we would avoid rhythm control with antiarrhythmic drugs. This is because usually the risk is more than the benefit that we get. So those are the different approaches with that. All right, so this is what cardioversion looks like, what it entails. So this is like a high energy shock that goes through the chest wall, and it basically shocks the heart back into rhythm. It's successful 80 to 90% of the time, which is amazing. Like it works super, super well, but not the most suitable thing because it's like a procedure. You have to prep the patient, sedate them, give them anesthesia, things like that. So this works to break the incorrect cycle, stop the arrhythmia, allows the sinus node to begin firing again with a normal sinus rhythm. You can see like the EKG strip at the bottom. We had our AFib strip, and then followed by that, it went back to normal. So that's the benefit. Okay, and then as for drugs, so these are successful relatively lower compared to cardioversion, which kind of makes sense, right? Like they're not invasive to the way that like cardioversion goes. They're successful 50% of the time, most effective when administered within 7 days of AFib onset. And then you can see like the class 1C and 3 antiarrhythmics listed here for your reference. Like class 1C, the key thing, we can't use these with structural heart disease, which again, very, very hard for us to find patients who are candidates for that. So you don't need to worry about knowing class 1C. From class 3, the only ones that we'll focus on quite a bit are amiodarone and dofetilide for the reason that's in red. So these are the only class 3 antiarrhythmics that are safe for use in patients with heart failure with reduced ejection fraction. So again, remember that statement. Yes?
Patients that have decompensated heart failure, are we going to keep aside the beta blockers then?
Yeah, we wouldn't be able to use beta blockers and decompensated heart.
So just like these two.
It would still be okay, but again, in that situation, the situation of decompensated heart failure, decompensation in general, the primary goal becomes priority to stabilize our hemodynamic status. So first, fixing that problem, like getting the patient out of that shock state. Once we are stable and out of it, that's when we can approach our rhythm concern, like our rhythm disorder, if that makes sense. So it's all kind of connected. But yeah, that would come first. Hemodynamic instability needs to be fixed first. That is a very good point. But yeah, and then once that's fixed, that's when you can introduce our rate control, rhythm control. Okay. All right, so getting into amiodarone, this again is like our most commonly used antiarrhythmic, class 3 antiarrhythmic. A lot of clinical considerations with its use. This is a super, super long half-life drug, 40 to 60 days half-life. It sticks around in the body for a long time, accumulates in the body tissues, and can cause a number of toxicities and side effects. So a lot of problems with this. The things that should stand out to you, I've colored them in red. So just keep those in mind. Photosensitivity, which is a little bit of a unique thing with amio. It can cause this like slate blue skin discoloration, which I have seen in real life before. It's very scary. Like these patients, it looks very scary. Toxicities wise, the ones that you ought to keep in mind, and I guarantee, like, if you get an amio question on the boards, it's definitely going to ask something to this effect. Thyroid dysfunction is a possibility. Pulmonary fibrosis is a possibility, and then hepatotoxicity. For that reason, we have to do function tests that correspond to those organ systems. So like thyroid function tests, pulmonary function tests, and liver function tests. PFTs, TFTs, and LFTs. Okay, those are key, and I'm pretty sure I've asked like a question regarding that on Top 200. So yeah, that definitely will be a thing, not only for the exam tied to this, but like you'll see that in the future for sure. As far as drug-drug interactions go, so as you can see, there's like a bunch. The really important one to know is the one again in red. So when starting amio, decrease the dose of digoxin and warfarin by 30 to 50%. You've seen that before. Again, I think I'm on Top 200. I definitely asked a question with warfarin and amiodarone. That is a major drug-drug interaction. So we empirically dose reduce. So I would keep that in mind for sure. And the same approach is applied with digoxin use. So that is that. And then you can see statins too listed there. Clinically, the use of simvastatin and lovastatin is not that common. So I wouldn't worry about those. Like, don't worry about memorizing the dose or anything of that sort. Just, again, all the things that are in red here are what are key. Okay, and then this is just to give you a sense of how often we're keeping tabs on everything tied to amio. A lot of like different things, but just, just so you know, like how often do we keep an eye on our function tests? And also like just with the eyes, like photosensitivity, that's, only as needed. But as you can see, like at baseline pretty much for everything. And then it's either annual, every 3 to 6 months, every 6 months and such. All right. And then here you can see, this is just an overview sort of image to give you a sense of like structural heart disease versus no structural heart disease, where our antiarrhythmics fit in, where catheter ablation would come into play, and such. I wouldn't worry about like being able to completely interpret this image. It's just an overview sense of like kind of how we approach everything. And then catheter ablation may be considered first-line therapy for patients with paroxysmal AFib only. So the kind that like the onset happens and then it resolves on its own. Like it's kind of like that labile fluctuating sort of type of AFib. So not necessarily applicable for every kind. So that's something to keep in mind. We'll go into catheter ablation next. So this is a low-risk procedure that scars or destroys the tissue in the heart that's causing inappropriate electrical signals to create abnormal heart rhythms. It happens usually in something called the EP lab or cardiac cath lab. Cardiac cath lab is the same place where our PCI occurs, PCI from acute coronary syndromes, which we talked about like 2 exams ago. Reasonable option for patients who remain symptomatic despite antiarrhythmic drugs or as an alternative to long-term antiarrhythmic medication. So again, just to compare this to direct current cardioversion, that's done in more of like the acute state. And then catheter ablation is done more of like the maintenance approach. So just trying to make sure that the patient stays in normal sinus rhythm. Just some practice, list major toxicities of amiodarone. Again, keep in mind the PFTs, LFTs, and TFTs, and you'll be good. And then we have a patient with digoxin, 0.25 milligrams daily. And assume this patient is being initiated on amio today to attempt to achieve rhythm control. What changes, if any, should be made to his digoxin? So what would we do with this drug-drug interaction? What do you all think? Yep, so reduce by 30 to 50% the digoxin dose, and an easy half of that is 0.125 milligrams a day, which is practically doable. So that would probably be the easiest solution. We would just cut the dose in half. Okay, any questions about everything that we covered? Okay, fabulous. So now we will get into stroke prevention, which is going to be a little bit of review of anticoagulation. So you already have gotten a sense of that already. So already went over this a little bit, but just to review, essentially, AFib could lead to thrombus formation. That thrombus or clot could eject from the heart, and then that could go to the brain. That could cause a stroke. Okay. Long-term anticoagulation should be considered, but we use like scoring criteria to determine if a patient is candidate for anticoagulation or not. And then the patients who are undergoing rhythm control strategies via cardioversion, they need to receive short-term anticoagulation. So we'll go through the details of that next. Prior to converting a patient to normal sinus, either via electrical or pharmacologic means, patients should be assessed for the need for anticoagulation based on the duration of AFib. So if the AFib has been going on for less than 48 hours, then you would start anticoagulation immediately and then do cardioversion thereafter. If it's been longer than 48 hours or you don't know how long the AFib has been going on, then administer anticoagulation for at least 3 weeks before undergoing cardioversion, or the patient would undergo a scan or TEE to rule out the thrombus. Because again, if there is a thrombus, or if there isn't a thrombus, then anticoagulation would not be necessary. So those are the different approaches. Like time is what matters here to measure that. Yes. Which one is cardioversion? Cardioversion is what we discussed as like shocking the heart back into normal sinus rhythm, done more in the acute state. So like just to go back to that slide. Right? Where did it go? Did I go too far back? Cardioversion. Here we go. My bad. Okay. Yes, so this is what we would do. So less than 48 hours, you anticoagulate, followed by direct current cardioversion, this procedure. And then in the situation that we don't know how long the AFib has been going on for, that's where we would make sure that 3 weeks of anticoagulation takes place before. Or they are scanned to make sure that there isn't a clot in place. Okay, because the thing is that AFib and clotting risk is high. Like generally it's just considered, they go hand in hand. Because as we discussed, there's blood stagnation that occurs in the left atrium as a result of ineffective atrial contraction. Okay, so clotting risk is a thing, and that's why we have to like anticoagulate for short term, if not long term. Okay. So that is the approach that we take. And then all patients who are cardioverted should continue anticoagulation for a minimum of 4 weeks after cardioversion, with long-term anticoagulation decisions that are made on the patient's CHA2DS2-VASc score. Okay. Any questions about this? So again, more of like an acute management, what we would do again, like in the hospital setting. Okay, here is the CHA2DS2-VASc score. I use this all the time. Very, very, very like clinically relevant. For your purposes, you will not have to memorize this criteria. I will give it to you. The only thing you have to do is add up the numbers. Okay, so just make sure to do that correctly. You can see as part of the criteria, heart failure, hypertension, patient's age. If it's like above 75, they get 2 points. If it's between 65 to 74, they get 1 point. Diabetes, stroke, TIA, thromboembolism, vascular disease, and then the female gender, that gives you a point as well. So this is basically what we use. A score of 2 or higher for men or 3 or higher for women would call for anticoagulation. Okay, so that's how we would apply this. Again, this CHA2DS2-VASc score, it's only used for AFib. You don't use this for VTE. So like if a patient has underlying DVT or PE, which you covered with Dr. Hall, there's no such thing. The patient would need anticoagulation. But in this case, you just weigh like basically the risk for clotting, looking at all these factors. And then as an update, the European Society of Cardiology, they've removed the gender category. And it's expected that the ACC-AHA guidelines will do the same. It hasn't been done as of yet. Like we still do the CHA2DS2-VASc accounting for the SC. But at some point it's going to become CHA2DS2-VA. So like not going to have the SC at the end anymore, which is crazy. Just because it's thought that like the female gender, it may or may not be as important to factor that in when thinking about the overall clotting risk. Like you have to couple it with a lot of other decisions. So we don't necessarily have to account for that the way that we once thought.
Prof, in that case, where they remove the female gender, they still change the parameter from 2 and 3 to just 2, 2?
For
Because
that,
it's going to be a 1 extra for the female anyway.
yeah, so once it won't account for gender, and so pretty much I believe it will just be like across the board too. I'm gonna follow up on what they're doing now, but because it's not done in America yet, that's why I haven't really thought about it. But that is a good question. That is a good point. I'll check what they've decided to do as far as points go, and then when they would start anticoagulating. But yeah, that's a good point. And then here's another set of criteria. This is done occasionally, not all the time. CHA2DS2-VASc is used very often, again, to weigh the clotting risk. Sometimes we take into account what the HAS-blood score is for certain patients, again, if we have concerns for bleeding. So in simple terms, this is our risk predictor for bleeding. CHA2DS2-VASc is our risk predictor for clotting. So sometimes we're worried and then we basically see where the risk score is at. MD Calc has both of these available. That's why it's not really useful for us to memorize these. I just, at this point, just do it so often that I just kind of remember it now. But for the purposes, again, for your purposes, if you ever need to calculate the score, you will be provided it. And you just have to make sure you add all the points as it ties to the patient. So, but yeah, this is what the HAS-blood score looks like. And then the higher the score, the higher the risk for bleeding, essentially. So, there is no clear cut, you get this score and, say a CHA2DS2-VASc of a certain number, and then that would prompt you to go a certain way. This is all clinical judgment. So clinicians just have to weigh, okay, I have a high HAS-blood score and a high CHA2DS2-VASc score. What do I think I want to lean towards more? And clinical judgment is what prompts you to go in either direction. So that's how you would approach that. And then as far as treatment goes, we have our DOACs, which again, you've covered with Dr. Hall. Alternative is warfarin. Warfarin has our INR goal of 2 to 3 generally, with the exception of mechanical mitral valve replacement, which is 2.5 to 3.5. DOACs don't have any sort of monitoring. The only thing is with renal dosing, we have to account for renal dose adjustments, which we'll get into, but you already kind of know what these agents are. One thing I will point out, so in clinical practice, we will see primarily apixaban and rivaroxaban in use. I see dabigatran on an occasional basis, but I don't ever see edoxaban. So there won't be any questions on edoxaban for sure. It's just not a useful drug, and I'll explain why. Dabigatran dosing is there for your reference, and you can see details on drug-drug interactions as well as creatinine clearance adjustments. Rivaroxaban, you can see here, 20 milligrams once a day with food. You take it with the heaviest meal for best absorption, and then you would dose reduce if the patient's creatinine clearance is less than 50. And then apixaban, our most common DOAC, I think ever used, because there's the most amount of data with it, even in renal dysfunction. So it works well in dialysis patients too, which is awesome. Out of all the DOACs, this is kind of our only promising option. So this is a little bit unique. Something that we do in AFib is we would reduce the dose down to 2.5 twice a day, from 5 milligrams twice a day if the patient meets 2 out of the 3 criteria that we have, that being age 80 or greater, serum creatinine 1.5 or higher, weight 60 kilos or less. So those are the criteria that we take into account. This is on your guide, so just letting you know. Apixaban dosing, it's nuanced and something I do so often. If you have me as a preceptor, you're going to see this all the time, and clinicians always getting confused about this. So a lot of teaching that happens with apixaban particularly, so it will come up on the exam. And then edoxaban, it's there for your reference. The reason why it's not clinically as useful is because, as you can see, we can't use it in a creatinine clearance of greater than 95. milliliters per minute, which, as you can imagine, that's like normal renal function. So it's an agent you can't use in normal kidney function patients, which is like a limitation. So no point to really go to it. So bottom line, apixaban is the most common, followed by rivaroxaban, and then after that is dabigatran. Okay, and then DOACs may not be appropriate for all patients. So it just kind of depends, like what the patient has going on. Specific factors such as comorbidities, patient preference, drug interactions, and cost. And you can see the factors here, like reasons for why the patient would be on warfarin, include mitral stenosis, mechanical heart valve replacement. These are like just straight up indications that only warfarin has shown a benefit in. So DOACs, they won't be as efficacious. So that's the problem. And then end-stage renal disease or on dialysis, you can see warfarin or apixaban. And then if a patient had a recent GI bleed, then apixaban is considered relatively the safest option to start with or resume anticoagulation with. Okay, and then patients with AFib who are candidates for anticoagulation will continue therapy indefinitely with annual reassessment to weigh the risk and benefit. So just making sure you all covered the concept of provoked versus unprovoked VTE with Dr. Hall. Yes, no, maybe. Provoked or unprovoked VTE? No? Okay. Provoked VTEs are essentially the type where like there's an identifiable reason for what led to the onset of the VTE. So the guidelines say that anticoagulation has to be for at least 3 months. Okay, there's like a number essentially, like at least 3 months. Some patients truly they're good with the 3 months, and then their clot, like their body dissolves the clot, they're good to go. But in cases of unprovoked VTE, that's where you do it indefinitely. So I'm tying it to this because it's kind of like similar to unprovoked, where you don't know what led to the formation of the VTE. So that's why like you just want to be safer and make sure that the patient doesn't clot again. With AFib, it's sort of kind of like that, where we would be running the risk of running into like a clot or a patient having a stroke, essentially, if we ever stop anticoagulation for them. So that's why we have to watch for it. In the situation that a patient experiences a bleed with anticoagulation, you obviously want to like think about that. Like, do you want to continue? Do we get more benefit with continuing? And it just depends on the extent of the bleed. Like if they're having an internal hemorrhage, like you want to stop anticoagulation, like that's killing the patient. So watch out for things like that. But generally the rule of thumb is indefinite anticoagulation for AFib. And then you look out for signs and symptoms of bleeding, renal function, INR. This is for warfarin. And then in the hospital, we do it on a daily basis, at least weekly, depending on the patients. Like sometimes they're stretched out 4 to 6 weeks, and then every 4 to 12 weeks once they're stable. Okay, and then I think we're about to wrap this up, which is awesome. So just a practice case thing, there's a patient, 78-year-old female with a past medical history of hypertension who's being initiated on anticoagulation for AFib. We have a weight of 55 kilos and a serum creatinine of 1.7. So calculate her CHA2DS2-VASc score, and based on that score, do we want to start anticoagulation for her? Do we have an answer?
Yes.
Okay, yes. So let's walk through that. So we have a 78-year-old, which, if you remember, 75, like above 75, yeah, 75 up, you would get 2 points. Let me make sure. 65 to 74, 1 point, and then 75 and up, yeah, 2 points. Okay, cool. So 2 points for that, 1 point for being female, and then hypertension. So 4 points is what you should have. Any questions about that? Okay, and again, please don't get confused with what the European Society of Cardiology are doing. I just wanted to give you kind of like a heads up that it may potentially change in the near future, but as of right now, like in present day, we still account for the female gender.
Dr. Naeem, I have a question.
Yes.
I calculate like 3 per score, but we have to add the vascular disease as another point, or what?
The age. So 75 or up is 2 points.
2 points, and hypertension is 1 point.
And female gender. Yes, we are in America, so we still do the gender thing. Yeah, please don't get confused with this slide and this slide. Like, they're very close together, but please, 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 like, this is America right now. This is Europe, okay? So please read the thing at the bottom. My purpose was to prep you for what may change in the near future. Maybe by the time you're on Appies, it's going to be different. Who knows? So just don't be alarmed if it's different by that point. Okay, so 4 points for Chad's Vasc. So based off of that score, do we do anticoagulation?
Yes.
Yeah, so it's above 3, right? 3 or higher, we do anticoagulate for females. And then, say this patient's being initiated on apixaban for stroke prevention. What dosing do we recommend? 2.5 PO BID. Yes. So remember, it's BID dosing. Say I give you a multiple choice and it says 2.5 milligrams daily. Please don't pick that. It's BID. Apixaban is always dosed twice a day. So keep that in mind. The reason why are we going with the lower dosing? Criteria, yes. So the patient's weight is below 60 kilos. So 60 kilos or below. The serum creatinine is higher than 1.5. 1.5 or higher is the criteria. This patient is not above 80, but they meet 2 out of the 3 criteria. 55. So 2 out of the 3 means lower dosing. Okay, so keep that in mind. Any questions about that? This comes directly from this slide. This slide right here, apixaban dosing. You can see the deets there. Okay, and that brings us to the end, which is awesome. We are wrapping up before class time ends. So these are just some summary points. I won't read through them if you will. Again, my key recommendation for my questions would be to just use my guide. Make sure you can answer them. If you can, you'll be in good shape. So.